I'll do this. I'll show it to you.
So, Prakash, what I will be doing is I will just start and then you take over.
Sure, sir. So you can start, sir.
Yeah. So, good evening, everyone. So, welcome to the another session of NESI Virtual Operative Room. And this is the next in the series after we had a webinar, wonderful webinar last month. And this is an effort on the part of NESI to further enhance the educational program of NESI with its mentors. And we are quite fortunate to have us here, have with us here Dr. Suresh Sankla as panelist, who is a senior consultant and Department of Neurosurgery at FI Hospital and Global Hospitals. Of course, in the neuroendoscopy world, he needs no introduction. Thank you so much, sir, to be with us and joining us here. And I hope we'll be having a wonderful session. And our next panelist is Dr. Ravi Shankar, who is additional professor, neurotology unit at SGPGIMS, Lucknow. Welcome, Dr. Ravi. And after this, I would like to give the baton to Dr. Prakash Nair, who is wonderfully working for the webinar series and the virtual OR series for NESI. He single-handedly manages all the show. And I should congratulate Prakash. I always do. And he's a wonderful blue-eyed boy and budding, almost budded, I mean budded and blooming neuroendoscopic surgeon of the country and world. Dr. Prakash, please, I would request you to introduce the speaker. And without wasting any further time, we shall start the education proceedings. Dr. Prakash, please.
Good evening, sir. Thank you so much for your very, very kind words. So this brings us to another session of our NESI webinar. And the aim of the virtual OR is to convey the steps of a surgical procedure and deal with all the intricacies of the actual difficulties that one faces when we're actually doing the procedure. And today we shall have the workhorse of skull-base reconstruction, which Dr. Kripa Shankar will be talking about. He is an eminent skull-base surgeon and ENT surgeon who works in the Apollo group of hospitals in Chennai. And he will be taking us through this. So Sharat sir has just joined. Sir, good evening.
Hello.
Yes, sir. You can hear me, sir.
Yeah. Good evening. I'm still stuck in the. Good evening. I'm still stuck in the traffic.
Okay.
So welcome to all of you. So please carry on.
Yes, sir. Thank you, sir. Thank you, sir.
So without taking up more time, Dr. Kripa Shankar, can you share your slides and start with with your talk?
Thank you, sir. Thank you for the kind introduction, sir. So I'll share my screen. Minutes for audio. Is my screen visible, sir?
Yes. Wonderful Abhimanyu raising the chakra and fighting the Mahabharata.
Yes, sir. So
very nice.
I wanted to start my talk with some interesting scenes from Mahabharata. So this is a person who was very well capable of winning any war, but what he missed was that he did not plan his exit.
Wow.
So for every surgery, it is important to plan the reconstruction before we embark into the surgery. And in our armamentarium, we have multiple ways to reconstruct skull base. But the most important one is nasoseptal flap. So the other picture I wanted to bring in was of this unfortunate event, where you can see that how much ever we are deprived of flaps in the nasal cavity, nasoseptal flap will always come to our aid like Lord Krishna. We can use multiple different variations, even in a vessel depleted neck, even in a vessel depleted nose. We'll still be able to get some sort of vascularized reconstruction in skull base. So we need to give a lot of thought about it before we embark into surgery in the preoperative planning. So this is the Vishwarupa of Krishna. There are multiple forms of Krishna. There are multiple forms of nasoseptal flap which are going to help us. So I'll be introducing the workhorse nasoseptal flap today through my presentation. I am Dr. Kiruba Shankar and I work with Dr. Rupesh, Dr. Arichako. I am working in Apollo Hospitals, Chennai. So before I show the technique, I just wanted to tell a short brief on what is an ideal reconstruction in skull base. The reconstruction should separate the nasal airway and the cranial contents, and it has to support the cranial content. It has to be air and watertight. It has to withstand post-operative adjuvant radiotherapy if it is planned. And this thing separates all the non-vascularized reconstruction from a vascularized reconstruction. It should have a low postoperative morbidity and it has to restore normal CSF flow. As a rhinological perspective, I'll be looking at postoperative olfaction. I'll be looking at behavioral pattern of this patient. I'll also be looking at sleep and sexual function of this patient. Each of this we will come in a while. So this is the reconstructive ladder we will be using. We will be primarily talking about the septal flap, and then we will see what we can do if the septal flap is absent or we are not able to elevate any septal flap because of lack of vessels. Meta-analysis published in 2020 showed that the graft type did not make any difference in postoperative CSF leak. It was the technique and the flap used. So if the septal flap is not available, I look for other vascularized flaps inside the nose. I have a short note on that. And if none of these flaps are available, as in case of multiple revisions, I look at flaps pedicled from external sites like a distant flap. Primarily, I use more of a gallio-pericranial flap or a gallial flap or a temporoparietal facial flap can be used. We can also use a FAM flap or a buccal fat pad flap. I've used a palatal flap, and there are multiple different flaps which we'll be talking in detail. So from 2000 to 2004, it was primarily that they were fixing the tissue defect structurally. After 2006, nasoseptal flap, which was introduced, primarily the reconstruction shifted from only structural fixation to specifically restoring the form and functionality. So this was a paper from 2005 from Professor Amin Kassam's group. They had reported a huge CSF leak rate of 10 to 35%. And this was primarily the best reconstructive protocol they had, that they use a subdural inlay graft. Then they use an extradural onlay graft. This can be a fascia lata or it can be a Duragen material. And then they used fat, and then they used fibrin glue. So this resulted in approximately 70 to 80% of skull base repair being successful and 20% of skull base repair which did not do well. Now, this ratio is actually the Pareto principle, in which 80% of cases do not require majority of skill. The 20% of the cases which we do needs 80% of our thought process and skill. So they primarily thought on how to go about it and how to improve the CSF leak rate. If you see nasoseptal flap, though it has been popularized by Gustavo Haddad in 2006, this was previously published and have been first described by a ENT surgeon called Hirsch. This was in 1952, where he documented two cases where he had recurrent CSF leaks and he had used a nasoseptal flap to rotate it. This was with the external approach. In plastic reconstructive surgery, this flap has been used in 1983 by Simonsen, and it was used for orbital reconstruction. But most popularly, it was used, it was published in Laryngoscope in 2006. This is the paper, and this showed a CSF leak rate of around 2 in 41 patients, which was around 5% CSF leak rate. The area of the nasoseptal flap was around 20 to 25 square centimeters, which was reported in this flap. And most of the variations had been described in the flap itself on how to extend the flaps to cover major skull-based defects. So this was primarily, some of the authors were from Romero and some of the authors were from Pittsburgh. So we will go a little bit about the anatomy, and primarily I wanted to show you that the most important place which should be looked for integrity is the sphenopalatine foramen. This sphenopalatine foramen is just lateral to the attachment of the middle turbinate, otherwise called as the stump. Now here we can see that there is an inferior turbinate artery and there is an artery which is going medially. This is the septal branch which is going medially. Now this goes under the stump and it comes over here and then it continues as the septal branch of the sphenopalatine artery. If we can see clearly, there is another branch which is going here. This is seen as a variation in around 70% of patients. You will have two nasoseptal or two or more nasoseptal branches. This branch is more closer to the sphenodosteum. So many times when we do a wide sphenodotomy or we inadvertently, we can have arterial bleeding, but worry not, you still have the major supply which is here. This is the septal branch of sphenopalatine artery. This is approximately 1.5 centimeters from the choana and then around 1.5 centimeters from the edge of the sphenoid flow. As soon as we go inside, it is first important to create some space. The inferior turbinate is most notorious to occupy the maximum part of the nasal cavity. It has got 20 square centimeters. This is a very good flap by itself, specifically in pediatric patients and those patients where the flap does not need more of rotation, and in those cases where nasoseptal flap is not available. We will come to that. What I do is like I first infracture the inferior turbinate and then we outfracture the inferior turbinate in such a way that there is no raw area in this surface which will avoid any fogging or spoiling our endoscope while we do the surgery. So I'll show you on how I plan. This is clival chordoma. We can see it here. And I'll just show you on how I plan the flap. So specifically during my preoperative planning, I mark the sphenopalatine foramen in this place. And then I measure from sphenopalatine foramen to the inferior most extent of where my exposure will end. It shouldn't go only on the sphenoid floor. You have to go up to the inferior most extent. I measure this distance as A. And then from here, I measure on how much I require up to the tuberculum. This measured as B. Then the total flap length which is required is A plus B. Now I take this A plus B length and I measure it from here up to the inferior turbinate. So if I just see how long the flap can be and then accordingly plan my surgery. Now, if the length is not sufficient, even when I come to the anterior mucosal incision, what I can do is like I can add a little bit of fat here and shorten the flap into a smaller A plus B so that the flap can be utilized. So this is a classical nasoseptal flap.
Surgery starts with
now what I have done is like I
marking
take the
and
first
elevation of
I
the
take the
large
inferior
nasoseptal
incision.
flap.
This starts from the roof of
The
the
inferior incision
nasopharynx, and then I extend it
along
on
the
to
roof
the
of the
floor.
choana.
This actually gives a little bit
Extended
of
onto the floor of the
extra length of mucosa. This has been described as a variation
incision
where you
further
can
extended
expand the
anteriorly
width of the nasoseptal
to
flap.
capture a
Now we
large
have to
circumference
identify
of
the
after having
mucocutaneous junction
good
here, and we
reconstruction
can
of
go
blood
flush
vessels.
with the mucosal edge, not including any skin. I use a monopolar cautery at 10
Once the incision is placed,
cutting
I
power.
elevate the nasoseptal flap in
Now
supraperitoneal
you have
plane. You
to
can see that
identify the
perichondrium is
plane. The
lifted
correct
onto the
plane is the
cartilage.
subperichondrial plane. In this patient, I have done a
Nasoseptal
suprapericondrial
flap
plane
is
where you
elevated
can
in
see that the
suprapericondrial plane.
perichondrium is going on to the cartilage.
This plane is
The cartilage
converted
will be very
into a
vascular and the
subperiosteal plane
mucosalization is faster.
as we proceed posteriorly
But once you come to
beyond
the
the bony cartilaginous
bony
junction.
cartilaginous junction, this is the place where the bony septum and the cartilaginous junction
We
are
complete the
joining.
elevation.
At that place,
You
I
can see
shift
that
to
we
a
are converting into a
subperiosteal plane. The
subperiosteal
subperiosteal
plane.
plane just rises very
And here you can
easily.
see
we have to identify
pedicle of
the
nasoseptal flap.
vomer, and we will be seeing a
In order to
vomeral
complete
ridge.
the flap,
So this
a
ridge
superior
will be
incision is
housing
placed
the nasoseptal flap pedicle. So I mark the
west of the
pedicle,
flap,
and after that I
which is
complete the
connected
superior
using a
incision
scissors.
with scissors.
This is done to preserve the
By
septal well
completing the
body from
superior
olfactory
incision
mucosa.
with scissors, I will be able
Once
to
the flap
avoid
is
any cautery
connected,
injury to the olfactory mucosa.
you can see that the flap is still attached anteriorly.
So after that, I come down, and
to
once
the
I elevate,
glenopalatine
I can
vessels.
see that there is
This
a
can
pedicle
cause
which is coming
bleeding
inside.
when you
This
elevate
is
the flap.
the pedicle from the greater
If
palatine
cauterized,
artery. This is
the
cauterized
flap is
and
completely
removed. Now I place this into the nasopharynx, and this is a classical nasoseptal flap which we raise. Now, what are the important tips at inset? So there should be no projecting septa in our graft bed. It needs raw bone, so all mucosal attachments should be carefully scraped off, and we need a raw bleeding bone. There should be no intervening material like surgicel glue. It is self-adhesive, so it does not require any adhesive material like a super glue or tissue glue which to be applied over it. Now, was it adequate? So there was a lot of enthusiasm when it came in. So in 2007, there was a study about improving the design of pedicle nasoseptal flap from our Pittsburgh group. They found that any sagittal approach, in those days it was primarily more of a sagittal approach. So any sagittal approach, when alone or in combination, a single side nasoseptal flap of 20 square centimeter was more than adequate to cover any defect. But if in case there is a larger defect, they wanted to use a bilateral nasoseptal flap. In 2014, there was a the long-term results were published about the nasoseptal flap of the effectiveness of nasoseptal flap when it is incorporated into the multi-layer reconstruction. And they found that the CSF leak rate drops to less than 5% if incorporated in a robust multi-layer reconstruction. We had our own paper from Mumbai. Dr. Nishit Shah had published skull-based defects if the nasoseptal flap can be reconstructed in infants. Hello?
Yep.
Sir, am I audible?
Yeah, Dr. Kripa, you are audible, please.
Okay, sir. Okay, sir. So there are some papers in which double flaps were used. So they raised nasoseptal flap on both sides, and this was used. When it was used sequentially, it is called as the Janus flap. Now, there are some literature on recycle of flaps. So many times when we use a nasoseptal flap and the other side flap has been used as reverse flap to cover the cartilage, we can use it as the nasoseptal flap from the first surgery can be utilized. It can be taken down and then replaced. There are lots of novel variations in which how to take the flap back by using CO2 laser and everything. But most of the times you will be able to take the original nasoseptal flap and reuse it. Sometimes there is flap contracture, and if we need a larger flap, there is a variation in which you can suture a mucosal graft, or you can overlay this flap over a mucosal graft. So these are the possible variations which have been described. So the classification was described by Moon et al. In 2019. The original flap was described by Haddad in 2006. So there are lots of conservative modifications, primarily because of the nasal morbidity the large nasoseptal flap was creating. So now a patient will have a lot of nasal discharge, nasal crusting. They can have nasal bleeding. Sometimes they can have an infection, septal abscess. I will discuss about that in a while. So the classical large nasoseptal flap had lots of nasal morbidity. So there was lots of variations in which a rescue flap was described, in which we just elevate the nasoseptal flap pedicle and we give a wide exposure to the sphenoid anterior wall, and the surgery is completed. If there is no CSF leak, then the nasal septal flap is left attached to the septum for mucosalization. If there is a CSF leak, then the nasoseptal flap was elevated at the end of the surgery. So this is called as the rescue flap. There is a reverse flap in which opposite side septal mucosa is rotated on to the donor side to cover it. There is a posterior nasoseptal flap, which is a smaller flap. This flap is elevated over the septal branch of the sphenopalatine artery, but it is shorter and it is tailored for the size of the defect and the length of the defect. This was published in 2018 by Barger et al. Now, there are ways of expanding the size of the nasoseptal flap. So we can use and we can extend it onto the nasal floor. This is by Batke et al. It can be extended onto the inferior meatus. It can include the inferior turbinate. It can also go onto the nasal side wall, and whole of the lateral nasal flap can be included over the same pedicle, and this will give a very large flap. Such large flaps can be used for pancreavectomy kind of a defect. Now, can we extend the length of the already long nasoseptal flap? So there was a study in which they have done a back cut of the nasoseptal flap. This back cut is done in cases where you can compromise on the width of the nasoseptal flap. We want a long, thin nasoseptal flap. Then we can see the nasoseptal pedicle, and we can give a back cut in order to inferior to the nasoseptal pedicle, so that the flap will become longer, bent on itself, but it will become a little narrower. Shastri et al. In 2020, they showed a pedicle dissection when extended into pterygopalatine fossa can increase the length of the nasoseptal flap. We can have double pedicle anteriorly. We can have alternate pedicles from inferior turbinate. These are alternate pedicle nasoseptal flaps. We can have composite modifications in which we can have bone, septal cartilage attached to the nasoseptal flap, and this can be utilized for anterior floor, skull base floor repair. So we can take the cartilage. The cartilage is attached to the nasoseptal flap, and this provides a vascularized cartilage which can be used as a rigid reconstruction of skull base. So these are the possible variations. In 2024, there was a septal butterfly flap in which this is based on bilateral ascending pharyngeal artery, where you can use you can combine the nasoseptal flap along with the nasopharyngeal mucosa. This can be utilized for a large clival defect. This extended the surface area of the repair to around 35 square centimeters. So this is the first variation. I can show you a small video in which I always, by the rule of thumb, I always take that the anterior end of the, in a normally pneumatized cellar sphenoid, the cellar floor can be easily reconstructed by a nasoseptal flap of the anterior length up to the anterior end of the middle turbinate. So you can see I've already given the cuts. All the cuts are given prior to elevation of the flap. And then you can elevate this flap down. You can see this is the superior cut which extends posteriorly. This carefully protects all the olfactory fibers. There is a small spur in this place, but this spur can be easily elevated without any nasoseptal flap tear. Now, there is no cartilage exposure. It's primarily more of this rigid bone which is getting exposed. And these bone can be removed in order to improve mucosalization. So in my series, I found that this reduces nasal morbidity in a quite a significant way as measured by the SNOT 22 scores. This is a smaller flap, but this flap will be adequate to cover any defect in the cellar region. So these are the various modifications. If the Haddad flap is not suitable, you can have a posterior ethmoidal flap based on the posterior ethmoidal artery. you can have a bipedicled anterior flap in which you can have a greater palatine vessel and lingual, the labial artery, superior labial artery vessels which will come inside. You can have an anterior ethmoidal artery flap. You can have a septal flip flap where you can have both anterior ethmoidal artery and posterior ethmoidal artery onto this. This is a very versatile flap which can be rotated onto the anterior skull base. The defects like cribriform defects. This is a very versatile flap. You can also have a greater palatine artery flap which can be used for reconstruction of the anterior most defects. These are the variations in the septal flaps. If the septum itself is absent completely, then we can utilize the lateral nasal wall for vascularized reconstruction. This is the posterior pedicle inferior turbinate flap. We can have a turbinal flap where you can have the mucosa of the middle turbinate and the superior turbinate. We can have a posterior pedicled middle turbinate flap, and we can have anterior pedicle lateral nasal wall flap, which can be used for the anterior skull base defects. So this is a lateral nasal wall flap, primarily a posterior pedicle lateral nasal wall flap. You can see that the whole of the septum is absent. I tried to look for the septal branch of sphenopalatine artery, which was sacrificed in the previous surgery. But this patient had a risk of high pressure CSF leak from the clivus. So I definitely wanted a vascularized flap. So before the surgery, I planned for a right-sided posteriorly pedicled lateral nasal wall flap. So the first incision goes on the superior surface of the inferior turbinate, just cutting across the uncinate process. It comes on to the frontonasal process of the maxilla. Once it comes on to the frontonasal process of maxilla, it can be extended superiorly to encompass a large mucosal surface into the flap. Now, when you come anteriorly, you have to go on to the anterior surface of the inferior turbinate. The surface of the inferior turbinate is very rugous. So elevation of flap is not as simple as we take it on the nasal septum, which is a relatively smoother surface. So we need to take a lot of patience in order to elevate this flap. It is very important not to fracture the inferior turbinate. If you fracture the inferior turbinate, just like how we started the surgery, it becomes very floppy and it is very difficult to elevate the nasoseptal flap, the mucosal flap over the inferior turbinate. So once I have completed the mucosal incisions, I palpate for the anterior end of the inferior turbinate and I give a small release incision. This incision helps me to elevate both the medial wall and the lateral wall of the inferior turbinate. Now you can see how I elevate the flap. After I give mucosal incisions, I make sure that I have clearly removed all parts of the perichondrium and periosteum. So I use a blade. This blade elevates the inferior turbinate from the periosteum. Now the mucosal flaps are again cut with the blade. So this exactly gives the cut over the periosteum, which is very essential not to have a torn flap. So I am sorry, it's getting replayed. So once we do that, then we will be able to reach to the posterior end of the inferior turbinate, and we will be able to raise a flap like this. This will be the pedicle into which there are two arteries which come inside. One is the inferior turbinate branch from the sphenopalatine artery, and then you will also have a major branch from the descending palatine artery. So this flap is very robust flap. This can be utilized to reconstruct the sella or the clivus. So there are pedicled external flaps which can be used. Pedicled pericranial flap has been very well described. A temporoparietal fascia flap has been described. A facial buccinator flap can be elevated, which can be rotated through the nasal floor. Pedicled temporal fat pad has been used. This I have been using in some patients where the buccal pad of fat can be easily dissected into the skull base defect, and this gives a vascularized reconstruction. We can use a facial artery musculomucosal flap, which is called as a FAM flap. I am a fan of this flap when I come for oral reconstruction, but this can also be utilized for posterior skull base defects, specifically the clival defects. This clivus has lots of patients where they come, the primary team would have utilized most of the nasoseptal flaps, so these flaps come in handy. So if the nasal cavity is completely vessel depleted or it is post-radiation nasal cavity, then I prefer two flaps, a free flap. One is radial free forearm flap when I need the flap to be very thin and pliable for only for lining. If I want a large three-dimensional volume, if there is a defect which extends into infratemporal fossa or the orbit, then I go for a anterolateral thigh flap. These are the only two flaps I rely upon. I've never needed any other free flap. So nasoseptal flap, apart from skull base reconstruction, can be utilized for reconstruction of other parts. It can be used for reconstruction of the palate. It can be used for reconstruction of nasoseptal perforations. It can be utilized as a composite graft for reconstruction of the whole external nose. There is a study from Dr. Vineet Vishwam and Dilip Panikar sir's team in which nasoseptal flap can be utilized to line the Rathe's cleft cyst as a wick in order to prevent recurrence. There is a cadaveric study which is of using the nasoseptal flap in reconstruction of velopharyngeal insufficiency. From Rivera Serrano, he is the person who described the rescue flap. So, of important note is synergistic action of gasket and nasoseptal flap, which has been very well described in literature. Of note is this paper from 2014, which says that the combined use of gasket closure and the vascularized nasoseptal flap will reduce the CSF leak rate from 5% to near 0%. So this is a scoring system which we use in our team. So we use the area of the dural defect, we use the CSF pressure head, and then we use other factors of healing, and then we zero down on a score. These are the ways we reconstructed these patients, and around 10% of patients we did not use any nasoseptal flap. We used vascularized flap, specifically the middle turbinate flap in the patients with lower score. But as we went down on more difficult defects and high flow defects, then we primarily relied on this combination of fascia, gasket, and vascularized flap. Our CSF leak rate percentage is approximately 10 to 12.5%, which is one of the lowest in this among the teams. So this is a small flap plug. This is a fat plug which can be utilized when the score is less than 6. You can see that there is a small defect here. This defect at the limbus can be easily plugged with a fat plug. And once this is plugged with fat, we can utilize a mucosal graft. This mucosal graft alone is sufficient for this cella to mucosalize well. These mucosal grafts are very easy to be harvested. This can be harvested from posterior end of the inferior turbinate, or it can be utilized from the floor of the nasal cavity. This nice flap can be utilized to cover the cellar defect. This allows for a very beautiful reconstruction of skull base. At the same time, the nasal morbidity is very, very small when you use a free mucosal graft. So this is post-operative endoscopy. You can see there is no crusting. This is at 3 weeks. Most of the nasoseptal flaps take 6 weeks to 8 weeks to at least show some sign of healing. But in this case, you can see that the nasoseptal flap pedicle is present. You can see the fat plug and the mucosal graft, how well it has healed. This patient's SNOT score was less than 5 out of 110. And the patient was completely comfortable, and we could not see any major crusting in the nasal cavity. So when the defect extends on to tuberculum and the score is more, this is a defect which is communicating to the chiasmatic cistern and the suprasellar cistern. You can see the defect, and you can see the suprasellar carotid artery, and you can see the ophthalmic artery. Now, we used gasket closure in this patient, and then we also used a nasoseptal flap to line it up. This is the nasoseptal flap which went on there and it has been lined up. It is not moving. Yeah, so this is a upper clival defect from a clival chordoma. Again, I have used a bony, that was a cartilaginous gasket. So I just wanted to show you the bony gasket and a nasoseptal flap. So once the gasket goes in place, then we can use a nasoseptal flap to cover it. It is important to see how the fascia lata has been flowered around the defect. And then this is a tailored nasoseptal flap. You can see it is narrow one. It is a tailored nasoseptal flap. It goes on, and these patients have a very low CSF leak rate. At the same time, their nasal mobility is also very low. When we have a very large
This is
defect,
Dr. Krupa Shankar from Chennai.
so when we have a large defect, then like clival defect, we can see that this defect is extending from petrous apex, from the mid clivus defect to a lower clivus defect. So first layer will be a underlace dural substitute. So this dural substitute creates a hydrophobic layer. The second layer is a fascia lata gasket. I utilize cartilage composite bone from the septum. Sometimes if the bony septum or the cartilage in the septum is absent, we can utilize the conchal cartilage by straightening it. Or we can even use a rib cartilage, which can be sliced onto the shape, and then we can utilize it for the gasket. This gasket not only protects a rigid structural buttress, but it also creates a reconstruction at a far more anterior level. I'll show you in some time. So the remaining defect is packed with fat to create a three-dimensional reconstruction without any dead space. Once the fat is packed, the nasoseptal flap is utilized to line this defect. So in some cases, I have sutured the nasoseptal flap onto the nasopharyngeal mucosa. In some cases, you don't need to. See, this is the tumor. And this is the post-op which is showing all the layers. This is the first layer, which is the hydrophobic layer. The second layer is the septal bone composite. The third layer is the fat. And the fourth layer is a nasoseptal flap, which will be lining it. Then I've used a Foley catheter bulb to stabilize it. And this is a Merocell nasal pack. You can see some pneumocephalus, but this is very usual. And then this pneumocephalus resolves in around 3 days' time. So this was a post-radiation chordoma where we did not have anything in the nasal cavity. So I've raised a lateral nasal wall flap here. Whatever was remaining, I have taken it up. I have lined it with the fascia lata. But I did not have any rigid buttress. In such conditions, you can either use autologous tissue, like I used a rib cartilage in this patient, or you can utilize some synthetic material like medpore, osteopore, which are available in the market in order to design the gasket cartilage. Now you can see this is the rib cartilage which is going into place. And once it is in place, it is rotated to snugly fit in order to create a watertight rigid repair. And this primary repair is watertight, and primary reconstruction and prevention of CSF leak completely relies on this flap. We do not rely on the nasoseptal flap to close the defect for us. It is essential for this graft to go and snugly fit. If it does not snugly fit, one sneeze from the patient, the whole reconstruct will come into the nasal cavity or the oral cavity, and the patient will spit it out. This will also create a high volume CSF leak, which can be problematic. You can have meningitis, and you can see how well this is going inside. And once this goes and snaps in place, then we use you can see that it snapped into place, and then we can use the nasoseptal flap. So you see now that is the rigid reconstruct. So So you have to inspect the repair all around, and then I rotate a mucosal flap over it.
Shankar, can we now conclude so that we
Yes,
can
sir.
take questions?
Yes, my slide is not moving. Sorry, sir. This is the post-operative cavity. This is my data, and this is my reconstruct. And the level of reconstruction. Sir, shall I conclude?
Yes, we can then take questions also because some discussion.
Yes, sir.
also.
Yes, sir. So this is the level of reconstruction which I was talking about. If we reconstruct the repair at this level, then we can create a cistern in this place, which is very useful when we are planning adjuvant in this patient. There are some complications I have encountered. This is a nasoseptal flap necrosis, which happened in one of our patients. I had used posterior based pedicle flap. There is a systematic review on complications of nasoseptal flap, which describes crusting, synechiae formation, mucosal formation of around 2%, and nasoseptal flap necrosis of less than around 1%. So this is a dreaded complication. We can have meningitis and CSF leak at the same time. We had a cumulative rate of around 5% of CSF leaks without CSF diversion. We do not use lumbar drainage in our institution. So other complications which we have seen is this is the septal collapse, which happened to a patient. This was done elsewhere, but this happened to a patient who developed a septal abscess following nasoseptal flap usage. They had used bilateral nasoseptal flaps, but then this patient had a saddle nose. The saddle nose deformity I have seen in my practice. This one unique complication which had in my series is that this patient developed a hot palate blister after I extended the nasoseptal flap onto the superior surface of the hard palate. This patient had a small burn in the oral side of the hard palate. Now, I just followed this patient for around 6 months, and she was completely asymptomatic for 6 months. At the end of 6 months, she had a huge palatal osteomyelitis with a palatal fistula. Now, this patient underwent a second surgery, and I had to use a palatal flap to close this, and I debrided the osteomyelitic bone. I classify my complications into a minor and a major complications. The minor complications are ones which do not require any surgical procedure. The major complications are ones which requires surgical repair. So this is one modification I use, but then for want of time, I'm cutting it out. So to conclude, you have to plan your exit before entry. Try not to rely on nasoseptal flap to close the leak. You have to have a watertight first layer of closure. Try to avoid the Brahmastra for small leaks. Nasoseptal flap is a big asking price to pay, primarily in terms of nasal mobility. So this is fluid dynamics, which I used to look at where crust formation happens, but this is a talk for some other day. It's a big asking price to pay, primarily in terms of nasal mobility. So I'm very happy to take any questions or any suggestions or any
I think you can mute it. There is some
fluid
audio
dynamic
playing.
comments to look at where crust formation happens, but this is a talk for some other day. It's a big asking price to pay, primarily in terms of nasal mobility. So I'm very happy to take any questions or any suggestions
can you
or
mute
any,
your? I think you can mute it. There is some
fluid dynamic comments to look at where crust
Shankar, can you
formation
mute
happens,
your
but this
slide?
this is a talk for some other day. Big asking price to pay, primarily in terms of nasal mobility.
So
I'm very happy to take any questions or any.
I think Shankar, there is some audio playing over and over.
Fluid dynamic comments. It is with somebody else. Where crust
Shankar, can you mute your slide?
this is a talk for some other day. Big asking price to pay, primarily in
It's the same thing repeating again and again.
So I'm very happy to take any questions or any.
I think Shankar, there is some audio. There is some audio issue from.
It is with somebody else. where trust.
Arifa, can you please look at what the audio issue is, because it is replaying over and over from somebody's slide.
It's the same thing repeating again and again.
So I'm very happy to take any questions or any.
I think Kripashankar, there is some audio issue from.
It is with somebody else.
Sir, I think someone opened the YouTube
Arifa, can
live.
you please look at what the audio issue is, because it is replaying over, and mute that audio, because otherwise you cannot start with questions.
Sir, is it okay now?
Yeah, but
Yeah.
Yeah, now it is okay.
Yes.
thank you so much,
Now it is
Dr.
okay.
Kripashankar, for a nice talk. And I think we can start with comments from the panel. And Sarath sir, would you like to start with your comments regarding the talk?
So yeah, it was an excellent talk, and I think it's a very, very useful talk. And creating a nasoseptal flap is very, very important for any surgery as a part of strategy. And the speaker he has explained it in a very nice and a practical way, what it should be for a webinar like this. So I can see there are a lot of questions in the chat box. At least I can see 4 questions. So perhaps the panelist can now take up the questions and the discussion.
So with this, Suresh Sankla sir, your comments. You have so much experience in skull-based surgery in the industry.
See, there are a lot of questions in the chat box.
There is already
I'm
4 questions.
I'm back.
already
So
something is
perhaps
going on.
the panelist can now take up the questions and the discussion.
Yeah, sure. Thank
So
you.
with this, Suresh Sankla sir, your
yes.
comments. You have so much experience in skull-based surgery in the industry.
See, there are a lot of
Yeah, yeah.
in the chat box.
There is
Sir,
already
I'm
4 questions.
back.
already
So
something.
Yeah,
is
can I-
see, it's my question again and again. It's repeating. I Questions don't know why it's repeating.
Yeah,
I
sure.
think
Thank you.
So with this, Suresh Sankla sir, your
yeah,
comments. You
I
have
think
so much
that
experience in
it was a very
skull-based surgery
very good
See, there are a lot
talk,
of
Dr. Kripashankar.
in the chat box.
There is
Sir,
already
I'm
4
I'm
questions.
back.
so many sounds are coming. So it is
Arifa, I would suggest that you mute all the others except the panelist. No?
Yes, sir.
Please allow only the panelist and the speaker to be on, and the moderators. The rest all joining attendees you put on mute. The echo from the someone hearing in the YouTube is again and again coming. We lost all the voice. Hello?
Sankla sir, can you hear us?
Suresh sir, can you please unmute yourself?
yes,
We lost all the voice.
Dr. Kripashankar, that was
Hello?
a very good talk on the
Sankla sir,
reconstruction.
can you hear us?
Yes, can you hear me? I am talking now.
Suresh sir, can you please unmute yourself?
Yes, sir, I'm able to hear you, sir.
Already unmuted. I'm already unmuted.
Lost all the voice.
I'm able to hear you, sir.
That was a very good talk
Hear you.
on the
Sankla sir,
reconstruction.
can you hear us?
Yes, I can hear you. Can you hear me? I am talking now. Of course, yes.
Suresh sir, can you please unmute yourself?
I am already unmuted.
Yes, sir, I'm able to hear you, sir.
Already unmuted. I'm already unmuted.
Lost all the voice.
I'm able to hear you, sir.
That was a very good talk.
Hear you.
Sir, there is a problem with Suresh
Can you hear me?
Suresh sir.
Sir,
I think
Suresh,
in Suresh
Suresh sir,
sir,
can you please
there are
unmute
two. One
I'm
is a
already-
Zoom,
Yes,
another
sir,
is
I'm able to
YouTube.
hear you,
Both
sir.
are activated, sir.
I'm already unmuted.
Lost all the voice.
I'm able to hear you, sir.
Now, why are our audios getting repeated again and again?
Sir, because of in Suresh sir side, YouTube and the Zoom both are open. There are two. One is a Zoom, another
sir, I'm
is
able to
YouTube.
hear you,
Both
sir.
are activated, sir.
I'm already unmuted.
Now, why are our
It is
audios
too
getting
difficult.
repeated again and again?
Too difficult
Sir,
to
because
talk.
of in Suresh sir and the Zoom both are open. There are two. One is a Zoom, another is YouTube. Both are activated, sir.
I'm already unmuted. Okay, can you hear me
Now,
now?
why are our
It is
audios
too
getting
difficult.
repeated again and again?
Both are Two, one is a Zoom, another is YouTube. Both are activated. So
I've already activated.
Sir, can you please close the remaining tabs in your laptop?
Everything is closed except for the speaker.
Two, one is a Zoom,
and-
another is YouTube. Both are activated. So
I've already activated. I have activated the mute button. So I am now, I can
Sir,
talk
can
to
you please close the remaining?
everything is closed except for the speaker.
two, one is a
Sir, can you please rejoin again?
Hello.
Then Ravi Shankar,
Yes, sir. Yes, sir.
yeah,
Uh,
I think
uh,
please give your
Yes.
comments from the ENT perspective, because you also deal with a lot of skull-based work where you use nasoseptal flaps for reconstruction. So you can probably give us some comments, and also one question in the chat box, which is
Yes.
regarding elevation of a flap in a patient who has a deviated nasal septum.
Thank you, sir. Kiruba, as usual, your talk is very nice and fantastic and lot of information. So the first question, can you answer the question that raised in the chat box? So, how will you deal with the deviated nasal septum?
Yeah,
Kripa?
so I'm not able to see it. Yeah, so now the deviated nasal septum needs more quantification. So many times it depends on the patient, it depends on the tumor. Now, if the deviation is a smooth deviation,
The chat box.
I'm able to see. Yeah, so if the deviation is a smooth deviation, we will be able to elevate the nasoseptal flap even if it is grossly deviated. Now, I always prefer the left-sided nasoseptal flap primarily because I want the endoscope in the right-sided nose. And yeah, so if, sir, it is getting replayed again and again. So if there is a sharp deviation like a spur, if there is a sharp deviation like a spur,
Understand this. Arifa, what is happening? No, just a minute, Dr. Kripa Shankar, please.
yes, sir.
Arifa, what is happening here? No, this is all getting repeated again and again. No, what is the problem? Bhai? Arifa, are you hearing?
Yes,
Sir,
sir, yes, sir.
Sumit
I
sir, you
think
can
issue
see
from
Suresh
Suresh
sir in
sir's
two
desktop.
devices. You can see now also.
Hello.
Hello, sir.
Yeah, sir, we can hear you, sir.
Yeah, you are audible.
Yeah, I'm audible now. Right. Yeah, this was a very good talk, Dr. Kripashankar, and you have really cleared the doubts in
Thank you,
everybody.
sir.
And we got to see so many videos of different approaches. And I'm very impressed with the way you close the entire skull base, anterior skull base, and some posterior skull base also using this technique. My question is that whether you plan it preoperatively, how do you close the particular wound, or you take the decision at the time of closure? How do you do?
So I always plan it pre-operatively. There are some tumors in which we do not anticipate a CSF leak. Now, there are patients who have a small cellular lesion which is not even touching the CSF space. In such cases, I do a rescue flap. But most of the times, whenever we think we are going to get away with a rescue flap, sometimes I need to elevate nasoseptal flap in that kind of a situation also. But there are some tumors where preoperatively we know that this is going to create a CSF leak like a clival chordoma with an intradural extension or a craniopharyngioma. In such cases, I preoperatively plan and elevate the nasoseptal flap from before itself.
Very good. How much do you rely on the artificial grafts available in the market these days? Are they really reliable and you use it very frequently, or you just try and keep away from them?
So multi-layer reconstruction for clivus, we use Duragen or Redura. That is the only artificial material I use. I also am impressed with Medpore which can come in handy in a patient who has a depleted nasal septum, or we do not have any other grafts or cartilages, then medpore can be used, osteopore can be used. By and large, I do not use any other artificial dermal grafts or the artificial acellular dermis. These things I have not utilized in my practice. Most of the times, I am able to get away with facial atta from the patient.
Okay. And what is your post-operative care of these patients where you have taken a big flap to cover or repair the big defect in the skull base? How
Yes,
do
sir.
you post-operatively?
So, post-operatively, I place this pack for around 3 to 4 days. And from the day I remove this pack, I start this patient on nasal douching. I refrain from suction clearance, but primarily a very good nasal douching will keep this patient asymptomatic and crusting at bay. I keep this patient under follow-up every 3 days in order to see if there is any mucosalization. But this patient needs a lot of recurrent outpatient visits, where this patient needs crust removals and to prevent the crust from forming, to prevent from infection from forming, and to prevent foul smelling discharge in the nose. So, when we do this at the end of 6 to 8 weeks and we have a mucosalized nasal cavity, then all the effort is worth it if we are able to take this patient out without a CSF leak. So that is what I do if I take a large nasoseptal flap. And I sometimes I use silastic sheets to aid mucosalization. I have placed some free mucosal grafts from the buccal mucosa. I have used some free mucosal grafts from the turbinates to place it between the cartilage and the silastic sheets. Sometimes these help. These give a head start in mucosalization. Once the mucosalization is complete, these patients stops complaining and the nasal function returns.
Correct. And in your experience, the free flaps taken from everywhere, are more reliable and you rely on them, or the vascularized flaps are more reliable? How do you, define?
Sir, as such, the vascularized flap have got a very low failure rate. Now, in my case, out of around 600 cases, I have had only one failure where I had a nasoseptal flap necrosis. But when we use a free flap, the need for the free flap is for a very large defect, and the CSF leak rate literature quoted is around 15 to 20%. So I utilize the free flap like ALT or radial free forearm flap only if it is inevitable or unavoidable. Otherwise, if I have a nasoseptal mucosal flap, I always go ahead with the mucosalized flap from the nasal cavity.
Can I ask a question?
Yeah, please go ahead.
So, what do you do in cases of recurrence? Let us say you put a nasoseptal flap already, you've exhausted all the flaps in the nasal cavity, and then patient come back with recurrence. Let us say tumor, you've given radiotherapy, and there is atrophic rhinitis, and it's opened up again. So, what are the options under such situations?
So, greetings, Saras Chandra sir. So, it depends on whether the vitality of the already mucosalized nasoseptal flap, sir. So, we have to also see whether the tumor has involved the nasoseptal flap. Now, if the tumor has not involved the nasoseptal flap and the vitality of the nasoseptal flap is still available, then this flap can be harvested again and recycled in the surgical situation. But the problem with this flap is that the flap would have become shorter, contracted, and become thicker, and it conforms to the defect's morphology. Now, once we elevate this flap, if we drill the remaining defect for expanding the bony exposure, this flap will not be pliable enough to fall onto the defect. The other problem I have seen is that this flap can have a very good thick adherence to the tumor itself. So many times there may be tumor which can get elevated along with the nasoseptal flap, or there can be a major bleeding when you are elevating the nasoseptal flap. So we have to be very careful, and we can use clear scissors. A supraperichondrial plane in these dissections will be useful. Now, if I'm not able to salvage the previous nasoseptal flap, I look at other flaps in the nose, the inferior turbinate flap, the lateral nasal wall flap, or a middle turbinate flap. These are little flimsy flaps. Apart from the inferior turbinate flaps, I don't really rely on any other flap. In such cases, I get a extended pedicle length. We had discussed the options of FAM flap. We had discussed the options of temporoparietal flap. I've used pericranial flap from anteriorly to line the whole of the skull base, primarily because some of these patients need postoperative adjuvant radiotherapy. Now, as such, for the morbidity, there has been lot of recent papers in which they go back to the original fat and avascularized flap. But in my practice, I always rely on a vascularized flap. Thank you, sir.
Nishit and his team often talk about the pericranial graft from the frontal bone to cover the defect at the skull base. What is your experience in that?
So pericranial grafts can be used, but the success percentage of pericranial graft as such falls around 10% below the vascularized flap. And the duration for a graft to take up is approximately 3 weeks. The duration for a nasoseptal flap to take up is approximately 72 hours. So in case of very high profile cases like a craniopharyngioma, I primarily rely more on a vascularized flap than a graft. Many times we will get away with the graft as evidenced by papers from before 2006. We still will have 80 to 90% success rate when we use a graft. But when we use a flap, the percentage increases and our success percentage is around 95%. So that small improvement is available if we use a vascularized flap.
Right. Thank you, Prakash.
Kripashankar,
Go ahead, Liti. Yeah, very nice explanation. Yeah.
Kripashankar, one question regarding your bone that you use for your gaskets. See, some of them will be for clavicle So have you had any experience of this bone undergoing osteomyelitis when you give radiation? Because you probably give proton, which is at 70, 75 gray. And it's not uncommon to see bone getting postoperative osteomyelitis when you give RT at this. So have you had any experience like that?
So the bone grafts which we are placing, I have not seen them going into osteomyelitis, primarily because these are thin pliable bone, and they can take up vascularity from the nasoseptal flap which we are using. I have seen osteomyelitis involving other part of clivus which are otherwise untouched. I have seen osteomyelitis with them, but never with a recon material.
But there's another question regarding lumbar drain. Any comments on the use of lumbar drain in your practice?
So we use lumbar drain sparingly, sir. Now, if the patient has any factors which predicts a post-operative failure, and I showed the scoring system, and if the scoring system exceeds 18, so which there are some patients where you have a post-radiated patient, and this patient does not have a reliable nasoseptal flap. Now, this patient is a hypothyroid patient, or there is some other factor which interferes with normal healing. In such patients, we use lumbar drain. But otherwise, this lumbar drain we don't use where I have a reliable gasket or a reliable nasoseptal flap which has lined it up. Then I usually don't use lumbar drain.
Thank you.
Dr. Prabhu, this is Dr. Ravi Shankar. Yeah.
Yes, Ravi.
Hi, Ravi.
So you usually house your adult in the nasopharynx, right? So in
Yes.
case of pliable lesions, how you handle your housing nasoseptal flap?
So when I'm doing a clivus, this it depends on whether we are doing the upper clivus or mid and lower clivus. Now, if it is upper clivus, I don't disturb it. I leave it in the nasopharynx. But if it is a mid or a lower clivus for exposure, we also add a transpterygoid approach in which the maxilla is completely open. So in such cases, I place the nasoseptal flap into the maxilla. And I also dissect a little bit of pedicle into the pterygopalatine space so that the pedicle length is quite long. And we have to be careful that it does not twist on itself, causing flap congestion. But otherwise, when we for clivus, if it is upper clivus, it is in the nasopharynx. If it is the mid or lower clivus, it is in the maxilla.
So the another concern is you told about you prefer left side, right?
Yes.
But thing is, we are right-handed surgeons, and most of the time we use our endoscope on right side. We have a full visualization on the right side, and we
Yes.
have better control on the pedicle on the right side. And most
Yes.
of the time we use the instrument through the left side, at which is blind. So it's a
Yes.
high likely we are going to injure the flap on the left side. Is it right?
Especially
I agree
from
with
the
the
shaft of the spinning drill.
Yeah, so I agree with the first part of your observation, Ravi. So I have also had a good thought about it. But once you elevate the nasoseptal flap and the pedicle is safe, I think we can avoid uh, the instruments hitting the pedicle primarily by being careful about it. The pedicle can get injured even with the right side when you are using drill or everything. But that is why I told you that I also dissect it a little bit into the pterygopalatine fossa so that the pedicle is completely away from us. And when I am drilling, I use the undersurface of the burr. I don't use the forward cutting area of the burr. I use the undersurface of the burr to get that part of the bone which is under the flap. And I've never had a flap injury in so many cases which we have done. But the advantage of having it is that even though this is in the left side, your neurosurgeon who is operating with you will have the right hand on that side. Are you getting my point, Ravi?
Still, actually, the visualization
Yeah.
won't be there. It will be.
No,
still there is
see if the nasoseptal flap is still attached up to the sphenopalatine foramen, the visualization will be low. But if you take down the sphenopalatine foramen and dissect it into the pterygopalatine space and keep this flap into the maxilla, it opens up the space. I am able to even do ipsilateral transpterygoid approaches without any problem.
right. So it's a fantastic talk, Dr. Prabhu.
Kripashankar, one more question.
Yes, sir.
We do a lot of anteriorly placed lesions transnasally, like olfactory groove meningiomas and CSF leaks also in that matter, where there is a large defect. And not only that, closure of that defect is very challenging because more anteriorly placed defect of this thing. We rely mostly on free flaps and fascia lata and many other things because the nasoseptal flap is usually falling short. What do you suggest for that?
Very nice question, sir. I have given a lot of thought about it. Now, we have to look whether we are wanting to lengthen the nasoseptal flap or widen the nasoseptal flap. Now, if we want to lengthen the nasoseptal flap, I had suggested one of the published variations in which you can give a back cut on the nasoseptal flap. We can raise a large nasoseptal flap and then you can give a back cut in order to extend the nasoseptal flap. With this variation, I am able to take the nasoseptal flap far up to the posterior table of the frontal sinus and up to the top of the frontal sinus it can go. Now, to incorporate the nasoseptal flap inside, we can do a large frontal window. Or we can also shorten the path of the flap by taking this flap over the lateral nasal wall, lateral to the middle turbinate. I line this onto the lamina papricia. And when this gets lined on the lamina papricia, it takes a very short distance to reach the anterior skull base, as we are saying. So by this way, we will be able to get it. But I will always not underestimate the length of the required nasoseptal flap, because it has happened with me sometimes that I have underestimated an anteriorly placed CSF leak and I have raised a normal the nasoseptal flap and it just falls short of it. So it is always important to raise a very long maybe a little thin, but a very long nasoseptal flap up to the anterior edge of the septum, and rotate it on if you are looking at a ethmoidal small defect. If it is a large defect and the nasoseptal flap is still not reaching, I won't hesitate to convert the reconstruction into a endoscopic pericranial flap and get it inside to line the anterior part of the defect. And over and above that, I will rotate the nasoseptal flap over it.
Thanks, Dr. Kripashankar. Thank you very much.
I request other speakers, other participants in this webinar to put questions in the chat box if they have any more questions, because we're coming to the end of our program and any other questions are welcome. Dr. Sumit, would you like to make some closing comments? Because we don't have any more questions.
Wonderful talk by Dr. Shankar. I mean, it's a thoroughly impressive experience of your closure and exit, as you described in your opening slides. And I really congratulate you for your phenomenal work. So before I conclude, if Dr. Sharath is here for his expert comments and final comments about the closure and exit for the anterior skull base.
So yeah, it's a webinar which has been done very well. So congratulations to Dr. Prakash and his team, and also to Dr. Sumit. So it was a very, very useful, and I learned quite a lot from this webinar. So congratulations to everybody. I don't have anything else to say.
Thank you, sir. And
Thank
we
you,
do look
sir.
forward for yet another exciting coming virtual ORs and webinars from the NESI, and under the mentorship of Dr. Sharath and Dr. Sankla and everyone who have been guiding us to sail through. And we sorry for the slight technical glitch that happened for today's webinar, and shall take care of that. Things should not be in future. So looking forward to see you all to join us for the next month's webinar for the NESI. And as usual, you've been so wonderful. And thanks again. Thank you so much. Bye-bye.
Thank you, sir. I'll leave the meeting. Thank you.